This scatter plot maps pediatric BMI against metabolic syndrome markers. Instead of a clear line, we see a data cloud with massive variance. You'll find youth with high BMI presenting zero metabolic risk, right alongside children with lower BMIs exhibiting severe cardiovascular and diabetic risk. Resolving this discrepancy requires us to apply a 5-level body composition model. In this framework, the tissue system level treats adipose tissue and fat as distinct biological components. This requires anatomically separating the fat located directly under the skin, the subcutaneous layer, from the intra-abdominal tissue buried deep within the body cavity. This visceral adipose tissue consists of the omentum and mesenteric fat, positioned strictly beneath the abdominal muscles. Clinical practice has often relied on the assumption that pediatric adipose tissue is a homogeneous reservoir, an inert place to store excess energy, but visceral fat is highly reactive. It is an independent endocrine organ that drives disease pathology, regardless of a child's total body weight. When we fail to differentiate these two types of fat, we obscure the actual risk profile. Clinicians are left without a clear view of the primary driver of insulin resistance and dyslipidemia. Accurately quantifying this internal tissue requires advanced imaging. Computed tomography and magnetic resonance imaging provide the gold standards for seeing true internal deposition. The definitive diagnostic metric comes from measuring the specific visceral area at the L4-L5 vertebral interspace. However, routine screening with these machines is restricted by high costs and the ethical constraints regarding ionizing radiation exposure in youth. This leads clinicians to rely on dual-energy X-ray absorptimetry, or DEXA, as the common clinical alternative for measuring trunk fat. But DEXA has a critical limitation. It cannot resolve depth. It is impossible for the scan to distinguish surface-level fat from the intra-abdominal mass beneath it. At the individual level, DEXA trunk fat readings only explain roughly 67 to 78% of the variance in actual intra-abdominal tissue. Without imaging, practitioners use surface-level proxies, specifically waist circumference and sagittal diameter. A sagittal diameter measurement of 19.2 centimeters is currently used as a threshold proxy for metabolic derangement, but the margin for error is wide. Estimating visceral fat from waist circumference alone carries a 33% root mean square error. While these proxies identify general central weight, they cannot isolate the critical ratio of visceral to subcutaneous fat required for an accurate risk assessment. If we zoom past the abdominal wall and bypass the subcutaneous tissue, we reach the membrane of a single visceral adipocyte, where the local chemistry explains why this tissue expands on its own. The body maintains a baseline physiological defense against internal fat accumulation through the lipolytic forces of growth hormone and sex steroids. During puberty, these hormones actively stimulate lipid release, serving as a protective barrier. This defense is opposed by insulin and cortisol, the primary drivers that aggressively promote visceral fat deposition. These cells have a unique metabolic appetite. Visceral cells possess a 2-fold higher glucose uptake rate compared to the cells found under the skin. When a high glycemic load raises insulin concentrations, it hits the visceral depot hardest, triggering rapid lipid deposition. Stress also plays a direct role through the hypothalamic pituitary adrenal axis. Within the visceral fat matrix, we find a high concentration of the enzyme 11-beta hydroxysteroid dehydrogenase type 1. This enzyme drives a specific chemical conversion, turning inert cortisone into hormonally active cortisol. This creates a localized feedback loop. Cortisol is generated directly within the fat tissue, often bypassing the levels seen in systemic plasma. This locally generated cortisol is delivered directly to the liver through splanchnic circulation, spreading metabolic dysfunction through the body. This endocrine threat is further compounded by the natural, transient decrease in insulin sensitivity that occurs during puberty. Because of the enzyme 11-beta HSD1 and its extreme insulin sensitivity, visceral fat is not a passive storage tank. It is an aggressive machine that creates its own positive feedback loop for growth. This vulnerability to visceral fat is often established through early life epigenetic programming. Compare growth trajectories of an average weight infant to one small for gestational age. During childhood, these smaller infants undergo catch-up growth, accruing mass to normalize total weight.
But by age 6, they possess 50% more visceral fat than peers, despite normal total weight. Beyond early growth, distinct genes dictate how fat is distributed, regardless of total adiposity. This regression graph tracks visceral fat accumulation relative to subcutaneous fat. For Caucasian youth, the slope sits at 0.23, but the slope for African American youth is 0.17. They accrue visceral fat at a 26% lower rate relative to their subcutaneous fat. The most extreme proof that visceral fat is independent of BMI is found in the South Asian thin fat phenotype. Indian infants frequently present with central adiposity and high insulin levels at birth, despite having low overall muscle and viscera mass. In many cohorts, between 50 and 55% of the variance in visceral fat levels is dictated purely by genetics. These developmental patterns and ethnic differences show that universal BMI charts are an insufficient tool. Metabolic risk cannot be determined solely by a scale. Let's return to that messy scatter plot from the beginning, where BMI failed to predict metabolic syndrome. Watch what happens when we replace total body mass with MRI-derived visceral volume. The data points align, revealing a direct correlation between high visceral fat and metabolic derangement. High visceral fat concentrations drive the transition toward fasting hyperinsulinemia, elevated triglycerides, and suppressed HDL cholesterol. In contrast, the subcutaneous depots in the pelvis and buttocks remain relatively metabolically inert. Because this deep tissue is so highly metabolically active, it proves to be uniquely vulnerable to targeted mechanical stress. There is a clear dose-response relationship between moderate to high-intensity aerobic physical activity and the reduction of visceral lipids. Structured strength training also provides independent beneficial effects on intra-abdominal adipose tissue. The most promising finding is that these visceral fat reductions can occur even if a child's total body fat mass remains unchanged. Moving forward, pediatric medicine must look beyond monolithic weight metrics. Effective clinical diagnosis must target the distinct pathology, genetics, and